is a clinical psychologist and a current postdoctoral research fellow at Brigham and Women's Hospital, Harvard Medical School, right? And her research interests focus on developing and testing trauma-informed and emotion-focused interventions for a very interesting group of clients: comorbid psychosocial trauma and chronic pain. In addition, she's interested in developing and testing trauma-focused clinical education and training programs for behavioral health and medical professionals. So there's, as you can hear in this bio, there's a lot of developing and testing, which is very much in line with this whole field of deliberate practice, which is about developing resources, testing them, and also spreading them, get more tests done, and then refining them. My name is Vidar Husby. I live in Norway, and I'm a psychotherapist. I'm a clinical psychologist, and I'm a DP supervisor. So I supervise people using deliberate practice as a method, and also I train trainers, teaching them some deliberate practice supervisor skills that is a part of our certification program within the IDPS. Yeah, my main mission is, I think we have all in common here, is to integrate practice as a core component in training. Okay, so that was the sponsored by part, and now for the interview. I'm really happy to have you here, Jolene. And when I came across your study, I thought it was super interesting. So I have a lot of things that I would like to talk to you about, and probably more than we will have time for. So can you tell us first why you decided to study therapist development?
Sure. Yeah. Hi, everyone. It's really nice to be connected with you all. So this actually started because, and when I was in graduate school working on my PhD, I was working in a lab with Dr. Mark Lumley, where we studied more emotion-focused and experiential therapy, specifically for chronic pain, which is, predominantly in the States, chronic pain is treated with CBT or acceptance and commitment therapy. So it is kind of a newer area of work in chronic pain. And as part of his work and running our studies, we saw that part of the challenge was helping therapists approach using these types of skills, because doing emotion-focused therapies and, helping chronic pain patients talk about trauma as a really difficult experiences is something that was not only hard for patients, but also hard for the therapists as well. Oh, yeah. And so a lot of people in our lab, a lot of the students did some variations of intervention studies using emotion-focused therapies for pain. And we thought, what if I also became very interested in just training and supervision in general. And so we thought, well, why not see if we can train a set of therapists in these types of skills? Of course, we had to make them sort of micro skills to make this more manageable for a dissertation study. But this is how it came about, just by kind of observing that these tend to be a bit more tough for therapists in terms of implementing these types of approaches.
So I really appreciate how you start out with a very a complex clinical population, right? And in this process you describe, you turn the focus to the therapist's ability to work with this group. That's very nice. That makes a lot of sense, I think. So and in this study that made me aware of your work, you compare two training conditions and see how they impact skill learning in the emotional processing skills. I wonder, could you give us a brief overview of the design and the two compared training conditions?
Sure. Yeah. So the study was a bit complex because we were sort of testing two new things at the same time. One is, can you train therapists in general in a set of these kinds of skills? Just focus skills on eliciting trauma disclosure and identifying important emotions and helping, patients label at the very least these emotions. And the other aspect that was new or we were testing is, does the type of training that the therapist received matter? So one training was a standard lecture, so just slides, some quiz questions built into those slides just to check for learning along the way, and of course giving examples and so on, but no practice at all. The therapist did not use the skills in any way during the training. And then the experiential training condition, they received the same information, so all of the same slides and examples, but instead of quiz questions, we paused after giving information about each skill and we had them practice it. So for example, if it was eliciting disclosure, I might give them kind of a brief case summary of a patient. And then I would say, now, how would you use the skill? What would you say? And then depending on their response, I would offer them some feedback and then they would try it again. And then might try it a third time as well, depending on how well they did. And then we would move on to the next skill. So both conditions were the same length, just the single session. And we tested their skills before, so at baseline, immediately after the training, and then at follow-up as well. And then compared the skills within condition and also between conditions.
Can you share with us the 3 sub-skills and describe them?
Sure. Yeah, I'm happy to, but I feel like I have to say this was completely arbitrary. So I made this up.
Yeah,
and that's important to note because, you know, of course, I've had training in these types of therapies, and I had also attended some ISTDP trainings. So I was using that a little bit to inform, but of course, the skills we ended up with were a lot less complex, right? Because we were working with graduate students and most of the vast majority of them junior in their training. So some of them had just maybe saw their first client for therapy ever.
I see.
And so I was thinking of ways of really simplifying this type of approach because it can be, you know, a bit complex. But the first skill, it seemed very basic, right? So can you ask a question to a patient to help them share something difficult from their past? So a trauma or a conflict or a difficult secret. The second skill was how to navigate defenses against disclosure. So essentially what to do when a patient shows maybe some hesitation about talking about something difficult. And I gave them 4 examples of ways that this might happen. One might be that the patient might go on a tangent, or they might even directly tell you, you know, I don't want to talk about this. This is too hard to talk about. Or they might say, I don't see the point. Why is it that I have to talk about this, you know, difficult issue? And so what to do in those situations, how to overcome those defenses. And the way I approach that is kind of doing a combination, teaching the therapist to do a combo of things. One is kind of acknowledge and the defense, give a rationale for why it's important, and then give a direct inquiry right after that. So that was sort of the structure of that skill. And then the third skill was probably the hardest for therapists to navigate, and that is identifying and eliciting adaptive emotions from the patient's experience. And so for that, I gave them a list of, you know, what is considered an adaptive emotion, when is it considered adaptive, right? So for example, anger is considered a healthy emotion when somebody has been victimized by someone, right? Or treated unfairly, or their boundaries crossed in some way. And so when a patient is describing that kind of scenario, we want to help them identify and label a feeling of anger, right? And then I gave them examples of some maladaptive emotions that might show up in those scenarios as well, and how to distinguish the two. And so the third skill was focused on that, just eliciting that adaptive emotion that fits the patient's experience, whatever they're describing.
I think it's really interesting because from the examples that you provide now, it seems to me that what you have made is a learning situation where both conceptual and procedural knowledge are kind of balanced. They are woven into each other.
Yes, I would say. Yeah, well, that was the aim at least, right? So a lot of, I just want to highlight that this felt like a huge risk to take because these were not skills that were available somewhere that I just adapted and put into the trainings, right? So we made up these skills. We didn't make them up. Of course, they're skills from treatments, but the kind of simple versions of them we created. And then we also created the training approaches. So testing two new things at the same time is always a little bit tough.
Yeah. Also, the students will have to learn this way, and they have to learn what they are the content, the therapeutic content. But it's I would love to have this stuff as a student, for sure, and I really felt like as a student, and also after graduating, doing post graduate education, continued education. That my capacity to learn, even I think my IQ is within the normal range, but still my capacity to learn was overrated sometimes because we were watching videos, emotional, evocative stuff where I fell short in difficult clinical situations, and then got this truckload of input on top of my already activated nervous system. And I think we sometimes we overestimate the learning person's capacity to process input. So this
Absolutely.
yeah.
And for a lot of the students we worked with, actually, the watching of videos was not the most common practice for supervision. Supervision was only showing up to, a meeting with your supervisor, telling them about your case, and then they might tell you a couple of things to do, and then that's it. There's no observation of the trainee in any way, even though there technically is supposed to be, right? As part of the accreditation criteria for programs and so on. And, there's probably enough just to meet the criteria, but it's not, for a lot of trainees, it wasn't an ongoing process. So a lot of the times the supervisors don't really see actually in action what the trainees are doing with their patients. And for a lot of trainees, the experiential training was a very new experience. And a lot of them expressed that, wow, I've never had any training like this before. How come this is not in program? So we got a lot of that, even though it made them anxious, I will note. So they were very nervous and very anxious, but it seemed like part of them also appreciated it.
Yeah. What kind of what's that anxiety about, do you think? What was your impression?
So they're meeting someone for the first time, me or the other trainer. I did the vast majority of the sessions. So essentially they're meeting the stranger for the first time, and then they have to do something really, really vulnerable, like practice skills that they just learned a few minutes ago out loud in front of a person they don't know. So I think that's a reasonable anxiety to have. This anxiety didn't show up much in the standard training, of course, because they didn't have to do any type of performance, right? But in the experiential training, I think it is a lot, right? To just learn something and then immediately have to apply it, and then also self-evaluate and receive feedback about your performance. So I think all of these things can be anxiety provoking for trainees, naturally.
It's a vulnerable position. And also being outside the comfort zone is like it's less safe.
Yes.
But also what's interesting, I think, is to notice that for most people, if we do this the right way, this anxiety is manageable, and it's like it's not it doesn't make training an aversive experience necessarily.
Yeah, of course. And the way that I think about anxiety in training is the same way that I think about it working, as a trauma therapist or anxiety therapist with patients, in that some anxiety is necessary for change, right? If we avoided all anxiety all of the time, the patient would not improve in their symptoms. And so I think the same goes for training, in that there is a balance there of supporting the trainee, but also helping them challenge themselves. And naturally, anxiety will come with that challenge, right? Or testing out something new or trying something in a new way. So I don't view it, of course, to an extent, right? We don't want to make our trainees afraid of learning and of supervision. But I think even talking to them about it, like, it's totally normal to feel nervous the first time you're trying this or doing something, right? So that kind of meta communication too can be helpful.
I'm curious about that. Did you do that too? Like, did you normalize these kinds of reactions explicitly?
Yep, I
Yeah.
did. I did everything that would be considered within the realm of what I think is supervision.
Yeah.
Right. So, because oftentimes too, the training and the experiential training commented on feeling nervous.
Yeah.
So of course, as the trainer, I had to address that in some way. I couldn't just ignore it, right, and say, oh, we're not going to talk about that, right? And I would say, of course you're nervous, you're trying something for the first time in front of me, someone you don't know very well. But, I would really appreciate it if you give it a shot and see how you feel. This is for you. So I would just sort of normalize and at the same time try to help them push through rather than say, you know what, you don't have to do it again. It's
Yeah.
okay.
Yeah.
Right. So kind of pushing through that anxiety gently.
Nice.
Mirroring what I would hope they would do with a patient,
Yeah.
right? Using these kinds of skills.
Yeah. I think it's very helpful. I mean, if we manage to do it, if we manage to balance challenge and support like that, I think people dare to try new things and to actually practice. And in my experience, that can be done. Like in most often, that's completely possible. So it's really nice that you did that, I think. So, an important question is, of course, you have to remind us of the length of the intervention, right? That it was a single session, right?
Yes,
Yeah.
single session, correct.
And what were your main findings in this study?
Okay, in terms of within or between groups or overall?
Overall.
Everything? Okay.
Yeah.
So everyone learned the skills. That's important to know. So both conditions led to some skill improvement from pre to post, and also some maintenance of the skill by follow-up. So this is everyone who was in the study. In terms of the between condition changes, we saw significant differences between the groups in that the individuals in the experiential training improved more in their skills from pre-training to post-training across all three skills. And for the eliciting disclosure skill, this difference between groups remained at follow-up, meaning that the people who are in experiential training were better at the eliciting disclosure skill at post-training and at follow-up than individuals who received the standard training. For the other two skills, we didn't see this group difference at follow-up.
Okay.
So that is for the working with defenses against disclosure and eliciting adaptive emotions, the experiential training initially led to more improvement from pre to post. But this difference between the standard and experiential was no longer there at follow-up. And this could be due to a lot of reasons. I think the first skill where the difference was maintained at follow-up is a very simple skill, right? It's just asking a question. So probably less likely that a lot of repetition is needed for skill acquisition for this type of skill, whereas the working with defenses and the identifying and eliciting adaptive emotion are a bit more complex. So I would guess that you need more practice, right? Or at the very least, some reinforcement of the skill over time before long-term skill retention would be there. And both conditions lost some of these two skills at follow-up as well. So you can kind of, if you look at the graphs, you can see a little dip in both of these skills by the follow-up time.
Yeah.
So those were the main outcomes in terms of the skills. We did also assess for things like self-efficacy.
Yeah.
Everyone improved in self-efficacy regardless of group. So we did not see any group differences with self-efficacy, and this is self-report. So this is what the trainees are saying about themselves when it comes to challenging therapeutic skills. And then also we added some questions in there specifically relevant to the skills that we taught as well.
I think this, yeah. So one hypothesis that you have now is that the more complex the skill, the more useful it is to practice, or the more necessary will practice be?
Yes, I think that in general, more practice than a single session is needed, right? So the reason why this was a single session is entirely practical, in my opinion, right? It was a dissertation study, had to keep it manageable in terms of time and completion. But I think for long-term skill retention for therapy, you do need at the very least, you know, even if the training occurs in a single session, consultation, follow-up consultation to reinforce the skills is probably needed to be able to reinforce the learning and also address any barriers that might come up when the skills are actually being tested in real life with patients.
Yeah. So yeah, that makes sense. And when you I'd like to go back to the therapist's reactions. We touched upon it a little bit, but in the study you provide, in the study you write that you provide experiential training that includes practice and feedback, and then and then you add and addressing the therapist's fears. That really made me curious. Like, can you tell us about this this addressing of fears?
Sure. So I think that part of the reason these skills can be difficult to use, I don't think is therapist-centric, in that I think, at least here in the States, in the US, these types of therapies are not taught very often. So there's a lot of focus on CBT, acceptance and commitment therapy, mindfulness-based therapies, and emotion-focused therapies in general. Graduate students and therapists have less exposure to. And I'm sure this varies a lot by field, right? Maybe if you're more in social work or counseling, you're more likely to encounter this than in clinical psychology. So one, there's not a lot of exposure that these students have to these types of skills. And two, there are a lot of fears that can come up when it comes to, I'll go by skill. So when it comes to asking patients or eliciting disclosure, the fears that were coming up were, well, what if the patient doesn't want to talk about that? What if this damages our relationship, right? So there were a lot of alliance-focused fears. Same for the second skill. So if I'm challenging a patient to keep talking about something that is hard for them to talk about, what if they never come back again, right? Or what if, right, all of these fears about rupturing the alliance. And the way I address that is kind of bringing up that the idea of avoiding alliance ruptures at all costs is not an adaptive way to think about the therapeutic alliance, because alliance rupture and repair is a part of therapy that is very effective, right? So I would highlight that for them, right? And kind of help them point out, like, oh, when there have been some instances where you felt like there was a rupture in the alliance. How did you know that was happening? What did you notice? Okay, do you think that you could catch that in these kinds of moments? And how might you talk about it? Right. So of course the training wasn't alliance focused, but if a fear came up about it, we would talk about that fear and why that it's not a reason to avoid using the skill altogether, right? So those were a lot of the fears that came up. I think some of the other fears were more related to, what do I do if the patient becomes overly activated? What do I do if the patient dissociates? So kind of the overestimation that the patient is very fragile, right? And cannot handle talking about difficult things, cannot handle feeling negative emotions or getting distressed, right? So fears about managing the patient reaction, and actually assuming that the patients will have an overactivating or dissociative reaction, when in reality, that is not the common reaction, right, that patients have. They might get really distressed, they might get anxious, right? But oftentimes it is within the realm of being manageable and helpful still. So those, I would say, were the main two fears that came up.
I think it's very interesting how I mean, all these fears come, many of them come from a very good place. It's like the wish to take
Mhm.
care. It's based on care for the client, right? But it
Mhm.
backfires if it holds back important interventions. And
Yeah.
I mean, my follow-up question to what you just talked about was of course how can training help? How can training help with these fears?
I think, well, on what you mentioned, I think acknowledging that it comes from a good place, but also helping them see how it might limit the patient's progress. So if our goal really is to give, let's say, give the patient the most benefit that we can from the therapy they're attending,
Mm,
if we are pulling away from distressing experiences in fear that the patient can handle it, what are we teaching
mm,
our patients,
mm,
right?
mm,
And how is this going to be useful to them? If our message to our patients is not only can you not handle your anxiety and distress, but I also, as your therapist, cannot handle your anxiety and distress. So I think finding ways to help trainees understand this model, but I think also importantly, in line with experiential training, framing it to a trainee or a supervisee of, well, how about you just test it out and see what happens,
yeah.
right? Because oftentimes it takes kind of a direct experience of trying something new,
Mm,
nothing bad happens,
mm,
and then the self-efficacy goes up, right? Like, oh, I tried this new thing, I asked this question that I thought they would have a bad response to, or I tried this new approach that I thought my patient would make my patient really distressed, and they were distressed, but overall it was okay, right?
mm,
So it does take that direct experience, I think, to help a trainee essentially lower their catastrophizing
mm,
about all of these things that could go wrong.
mm,
And I think that the supervisor's role as well is sometimes, it doesn't have to be something super complicated. Whenever you're talking about with a trainee trying a new thing or asking, doing something difficult, sometimes it's as simple as, okay, now tell me how you would say that to the patient. How are you going to bring this up? And just
mm.
have them do it rather than just talk about
Yeah,
doing the thing,
yeah,
right? But just help them try to generate the language and the style of how they want to test it out. And this gives you the opportunity as a supervisor to also see what this might look like, right?
yeah,
And offer them some support and help with tweaking if necessary.
yeah, yeah. I think that's a really an interesting moment in supervision. That leap from talking about to trying out. It's like a
Mhm.
procedural leap where you go to doing. I think that's really an important move for the supervisor to be able to do. Also for us as supervisors to get used to do that, to try it out.
Absolutely. And this, I have to give credit to Dr. Mark Lumley because he was my graduate school advisor, and he was also a supervisor of mine clinically in many scenarios. And this is his approach. So I learned this a lot from him of not just, and he mirrors this is what he says we should do with our patients. And this is also what he does in supervision, that instead of talking with your patient about doing something, just have them do something
Yeah,
with you in the session, right? So the doing part is really like where the change can happen or has a big opportunity to happen.
yeah. I remember, and I remember very vividly when I myself habituated to doing that, to take that step in supervision as a supervisor. And I remember in the beginning it was anxiety provoking to go from the safe talking about, which is a pretty
Mhm.
it's within the comfort zone, what I could say,
Yeah.
to actually trying it out, and also to specify it, to really specify what to try out, not only
Yes.
not only with vague learning goals, but really specific steps that we are now about to try to do. That's really to allow ourselves to become that specific.
Absolutely. I think that's such an important point you bring up because I remember I was a trainee not too long ago. I only graduated in 2022. So
Yeah,
it's still a very fresh experience for me. And
yeah,
I think that one of the things that was most difficult about learning therapy is the lack of a bridge between models and
Yeah,
theory and then implementation in a
yeah,
session,
yeah.
right? And I think a lot of programs rely on the models and the theory to teach their students how to actually do,
Mm,
and assume that knowing the model and the theory also translates to skill or
yeah,
translates to implementation. And I
yeah,
think that is a huge gap
yeah,
to expect students to go through through just by like going in a session and doing without any guidance on these, like you're saying, these concrete kind of learning goals of, okay, how do I actually use the skill? What does this skill actually sound like
mm,
when I'm talking to a patient, right? Like take, for example, something as simple as like cognitive restructuring from CBT,
yeah,
right? You can understand the idea of what that is,
mm,
but doing that, I
mm,
actually find that to be as simple as it is, what was one of the most challenging skills
mm,
to
mm,
learn how to ask
mm,
questions to facilitate this and what kinds of questions to ask
mm,
and how to address patient responses that were still sort of like maladaptive or
mm.
unhelpful, right? So I do think that is a big piece of it, what you mentioned.
I think it also aligns with a kind of a bias that we have that I think it's this is all my subjective like impression, but we really tend to, I think, to assume that as long as I know something about something, I also can do that something.
Mhm,
So we assume this as learners and also as teachers, and yeah, so this procedural leap over to the doing and
mhm.
supervision is kind of a medication against that. It's
Yes.
interesting to hear about how you went about it with it, and also when you say you use the word implementation. Like we hear about these things, and then we are going to session, and where we are about to where we have to implement what we have learned, right? And I
Mhm,
think that's really in such that's a such that's such a contrast from the playground that you describe in your intervention. Because in your intervention, you give them a safe place to experiment, right? They
mhm,
try a response that is pretty difficult stuff, I would say. Also a complex population that
mhm,
you work in, and I guess that you want to apply these skills to this population also, right? So
mhm.
it's a really tough clinical challenge, and you give them an opportunity to play around with their words to meet the skill criteria, and that's
Mhm.
just it's in such a contrast to the to implementing something that you have just heard about conceptually into a session with a real client,
Yes. Yeah,
which
it's
is
that
how I grew up.
intermediate step. Yeah,
Yeah,
how I grew up too. Yeah.
yeah, great. Okay, so also I would
We
like
have
to,
some, I'm sorry to
yeah,
interrupt you.
Ines, please.
One question for Jolene
Great.
that
Mhm.
Joanna asked. So Joanna asked, pre was before the training, post was after the training, and follow-up was after they worked with clients?
So it is, it's possible and probably likely that they did work with clients in between the post and the follow-up, but I did not measure that myself, if that answers your question. So it through their own training programs that they were in, it's likely that they saw their patients and worked with clients in between. However, that was not something I measured or asked them about how many clients they had or whether they had worked with anyone.
Good. Thanks, Jolene. What about, I had another question too while you were discussing that has to do with the stimulus that you used in the skill setter. So the post measure, you used skill setter for that as well, right?
Yep, I use Skill Setter for all of the like skills assessments.
Okay, and was it the same stimulus or did you use different clients for pre and post?
So that's a very good question. This was another thing that I made for this study. So I actually hired actors and I filmed videos of the actors portraying therapy patients in various scenarios that were kind of matched to the 3 skills that we were testing. And I had a set of 10 actors from diverse backgrounds, men, women, different races, and we sort of like I edited the clips down to the right length to what is usually included in SkillSetter. I'm not sure if anyone's used SkillSetter before, but the clips are usually relatively short, about maybe a minute or less each. And we randomized the clips across the 3 time points. So once we had our final set of lots of clips, we then just randomized a set of clips to where each actor was represented at least 1 time, if that makes sense. So each actor you saw in a different scenario, but the same actor in the pre, post, and follow-up time point.
Good, because I was wondering about when you were discussing how, so the differences between, so like the maintenance effect, like you said, so it was just 1 hour practice, probably not that long. And I was wondering if maybe the videos were different, or if that had an effect, but you randomized it, so it probably didn't. Yeah.
Yeah, ideally it didn't, but we made the clips, right? So there's always some kind of variability there introduced by the fact that we didn't use any standardized or previously validated measure of skill assessment. Not that there is that I know of, to be honest, of these kinds of skills. But yes, we tried to minimize as much as possible that by randomizing the clips, and also by keeping the scenarios pretty similar. I mean, we didn't have them say identical things for the videos testing each skill, but very similar things across the time points.
And also, out of curiosity, so you were providing on the experiential training group. I'm sorry, I'm dominating all the questions now, but
That's okay.
If you guys have more, please write them down. In the experiential training group, so would they get, how many rounds, this is just out of curiosity, of feedback would they get? So they would send it on the SkillSetter, then you would get expert feedback from the supervisor, right?
No, for the experiential training, the feedback actually happened in the session. So they didn't submit anything on the SkillSetter. They just did their pre-assessments on SkillSetter, and then they came in the training session, and the feedback would happen during the session. So I would play them a video, and this video was not included in the skills assessment. So it was a different separate video, and I would have them use the skill out loud. And then each person got at least 1 round of feedback, oftentimes 2 rounds of feedback. So they would test it out. I would give them feedback. They would try it again. And then oftentimes I would offer them a little bit more feedback. Oftentimes it was, okay, that was great. I wonder if you could say it in less words and be more direct. That was usually something, because trainees tend to really talk a lot, right? And use a lot of language to where sometimes what they're saying gets lost. So I would help them kind of sharpen their response a bit. And then they would try it again, and then we would move on to the next skill.
Great, thanks. That's it.
Okay. So I'm curious to hear also, after you have done this study and developed and tested training, what do you think are the characteristics of helpful training? What do we have to include for training to be effective, do you think?
When you say training, are you referencing training, for example, of like holding a training for a type of therapy, or supervision?
I'm thinking of,
because I don't think those are different from one
yeah.
another.
What do you think are the key ingredients in skill learning?
Skill learning.
Yeah.
Well, I think, of course, I mean, this is no surprise, but some form of experiential or some form of doing something during the training, or during the supervision. And I think that that is also related to the idea of anxiety, right? And good anxiety. And what I mean by that is doing something new, or for the first time, or testing something out, feeling a little nervous, but getting to the other side of it, right? Either by repeating or by just staying with it long enough to where it feels manageable. And also being able to practice the language and the application of something that you maybe have only learned about as a model or in theory. I think also, I mean, of course, similar to how change in therapy happens, I think the alliance piece is important, especially in maybe smaller trainings or in supervision. Kind of meta communicating about the like supervisory relationship, especially if you notice that, you know, you may have done something with a trainee that made them a little nervous, let's say, or you sense some change there. So kind of bringing that up and talking about it, you know, I sensed that when I asked you to practice this or say it out loud, you know, you felt maybe a bit nervous. Am I getting that right? Like, tell me about that. Is there a different way I could have you do this next time that feels like a better fit for you? So just kind of making it more collaborative, especially for junior trainees just starting out. You know, I remember when I did therapy for the first time in my program, I was just handed a patient and I had never done therapy or counseling or anything similar in my life. And here I was responsible for someone's, you know, severe depression, and high suicidality, right? And I just had like nothing but the models that I'd learned in psychotherapy class to go off of. So I think some kind of bridging would be helpful. And this is nothing, you know, against the supervisors I had. Everyone was great. I really loved my program. But I think just sometimes in the busyness of life and the routine, these kind of smaller details of where change happens can really fall by the wayside, and we can kind of go on autopilot. Like, okay, trainee comes in, they go through their list, right? And maybe they have one really challenging case. We focus on that. I tell them what to do, and then supervision's over, right? And there's just a lot of missed opportunities there. So I would say like noticing if that's happening as a part of good skills training, and trying to introduce even maybe small tweaks to how you go about helping someone learn something new. It doesn't have to be a major overhaul or shift. I really like the idea of doing kind of micro versions of things, right? And so, yeah, it can be as simple as, you know, tell me how you might say this to a patient, or, you know, these just kind of smaller tweaks that can bring something from theory to practice.
So to summarize, also I bring in something that you mentioned earlier. You mentioned repetitions and feedback as part of the doing. And also you describe something that we also are very conscious about, which is reaction monitoring, right? To notice reactions to going out of the comfort zone, of doing the skill, right? And to make it collaborative, and to do alliance work in the supervision, and bridge. If I understand that point correctly, to bridge models to the reality in a way, to bridge the theory to what we are doing. This balance.
Absolutely. And even using your experience as a supervisor, right, as somebody who has seen a lot more patients than your trainees, when the trainee is practicing something, and you could even say, like, you know, oftentimes I've had a patient say this back when I brought this up. How do you think you would go about this challenge? Right. Just any of that, I think, would fit in what you just mentioned, this kind of bridging, right? Because it's not just therapy is not just the trainee says one thing and the patient responds and that's it, right? It's an ongoing and unfolding. And so the trainee has to feel like they can handle the potential unfolding of what might happen when they try something or try to implement something, in order to feel confident in trying it.
Makes sense. So I also wonder, so I have to be a little bit conscious of time, because we are approaching our 60 minutes. But so I'm going to ask you a last question, so for us to have some time in case anybody else wants to ask something. There's a term that you use in your paper, you write about adequate training, right? And I wonder if you, after having learned what you have learned from this study, how do you envision adequate training in emotional processing techniques?
Big question.
I know.
Adequate training. To be honest with you, I don't remember what exactly I used that phrase to reference.
To be honest with you, I don't either.
What? Adequate training. I mean, this varies so much based on what, I mean, even in the world of emotion focused and experiential therapies, there's a lot of subcategories of that, right? So, I mean, prolonged exposure therapy can be considered a experiential therapy, right? And that has a very rigid set of criteria that you have to meet for you to be certified in prolonged exposure therapy, right? That's different than kind of more emotion focused techniques like the ones used by my advisor, Dr. Mark Lumley, where it is more kind of a combination of identifying adaptive emotions, some things you might see in ISTDP, and also, empty chair technique, all of these kinds of things. So bringing in a lot of those aspects. I think the more flexible, this is something that's really challenging. The more flexible that the therapy is that you're training, the harder it is to identify what is adequate training. Because I think for the therapies that are a bit more structured, like prolonged exposure, to use that as an example, there is a very specific set of things that you have to be able to do as a therapist. And if you cannot do those things, then you are not certified, right? And so that's not adequate training. You have not received adequate training. And so it's a tough and challenging question. But if I could summarize what maybe a therapist has to be able to at least approach doing, it would be, one, to not be afraid to talk about difficult and traumatic experiences. And this doesn't just go for patients who are seeking treatment for PTSD or trauma specifically, because the vast majority of our patients have had some type of adverse experience. At least in the US, the vast majority of people in the US have a history of some type of adverse event that is hard for them to talk about, to bring up, right? And it may not be the single source of why they're seeking therapy, but it's certainly a contributor, right? And it's usually an important target for emotion-focused work. I think too, it would be to be able to understand the idea of why emotions are something that can be targeted in therapy. So oftentimes here, not that emotions don't come up in things like cognitive behavioral therapy, but they're not the mechanism that it's targeted, right, as a mechanism of change. And so there are a lot of models that can lead to that, and what constitutes adequate training really would vary by model, I would say, and who the patient population is. And then I think some capacity to tolerate distress or anxiety in patients and not take that as a sign of backing away from the experience in the session. So I don't know if that answers your question. So I don't have an answer of how many hours of training is enough. I think that varies, how much consultation is enough consultation. That really varies by what you're learning.
So I really appreciate your answer, but I also feel that I have to clarify it because I can hear from your answer that it's a huge question. And what I'll also, if we kind of differentiate between what we learn and how we learn, right? What would be the we now talked about. What would be the content of an adequate training, but if we look at the form of adequate training, like what would be the pedagogics of adequate training? What do we need to include pedagogically as a learning method, regardless of what is taught, in a way?
I think information, so model, examples, modeling is helpful. So showing the trainee how to do, and then having them do,
Yeah.
and then having them receive feedback about
Yeah.
doing, and then repeating
Yeah. Yeah.
and also observing, so watching videos of the trainee with
Yeah.
real life patients if you have access to that.
Mm.
If not, if you don't have access to videos, which I had a similar training experience where we could not record, my supervisor would have me do like these very complex process notes
Okay.
about the session. That way there was a lot more detail about what happened, not just the very brief note that we had to put in the medical record. So having some way to know the details of what's happening and offering the trainee feedback from that perspective.
Yeah.
Hopefully that answered your question.
Yeah, perfect. That's very nice. So thank you very much for that. That's I think it's really interesting to hear with different words things that kind of it's very much in line with what we teach and do, and yeah, it feels like meeting a colleague, and that's very nice.
Likewise, thank
Yeah.
you.
And then so I see that we are approaching the end of this talk, and I just want to check in with the audience before we close it up. Are there any questions that you want to ask Jolene before we close?
I do see one in the chat. I
Oh,
can
yeah.
very briefly mention the name of the program.
Yeah.
It used to be called TheraView. Now it's called SkillSetter, skillsetter.com, and I can put that here. They did not pay me to use their program. They just very kindly allowed me to. They are very, very kind to researchers and supportive of researchers. If you're someone who's studying training or supervision, they really just love to offer help to people studying this kind of thing, skills training. So feel free to reach out to them. You can, I think, on their website submit for a consultation. But yeah, they were very kind and helpful.
Great. So I think all of us, I know most of you attending here, and now you a little bit, Jolene, and I know that all of us, we are trying to improve therapist training and supervision, and also the clinical culture that we have that really leans towards theoretical learning at the expense of doing, and to balance that better is something that we all work to see happen. So I think saying yes to us to participate in this webinar, Jolene, is a gift to that effort that we are trying to do. So now we can. It was really nice to meet you, and we have all got interesting stuff to think about, and this webinar will live on online. So it's a good contribution, I think. So
Yeah,
I just
thank you
want to
so
thank you
much.
very much.
Of course, and thank you for having me. I will put my email in the chat if anyone has any questions, or if you want any of my materials. I'm happy to share anything I used in my study. Yeah, or if I can be of help in connecting with SkillSetter or anything you need, feel free to reach out.
Great. Thank you very much. Okay, so I suggest we close it up. Our hour has passed, and it's been really nice, Jolene, and thank you very much to you all attending. It was very nice to meet you.